Thank you, Benjamin. Again, welcome. We're so glad to have you here. We're very excited to continue with our series. Benjamin, if you can go to the next slide, we'll go ahead and get started. As Benjamin mentioned, we are going to be recording this session so that you have a record of it afterwards. We'll send out a link so that you can view the video, and you can also forward it on to your friends, your family members, your colleagues. We want as many engineers and clinicians to have this information as need it. We just ask that you do not sell anything. Benjamin, we can't actually see the slides changing. Would it be best if I shared my screen? Okay, I think Benjamin's having a little bit of trouble. There we go, okay. So we want to talk a little bit about what Project ECHO is about. The foundation of our conversation today is love and respect. Respond kindly rather than react if you disagree. We welcome all of you to participate in our discussions, but it's everybody's responsibility to keep ECHO a safe space. Please test your equipment ahead of time. Make sure you mute your microphone when you're not speaking. You can do that in the bottom left-hand corner of your screen. And whenever we start discussion, please remember to unmute before speaking and also introduce yourself and where you're from. Please speak clearly and stay close to your microphone, especially if you're in a group setting. Though do remember, as this is about COVID-19, we do want you to be responsible with your social distancing and try not to gather in large groups. If you have IT issues, please send us a message through the chat on the right-hand side or through email. You can talk to us at assisthtm@assistinternational.org. And Dr. Mez has kindly shared these tips in the chat, so you can reference them as we talk. So after this introduction, Guna will speak first about ventilators, and we'll hear a special case from Benjamin. We'll also have a bit of discussion before moving on to a didactic about oxygen concentrators, again by Guna, and we'll see a PM from Benedicto. And we'll get to close with the discussion again. I wanted to quickly summarize what we discussed in session 1 because it is so key to all work done by biomedical engineers. COVID-19 is a very stable virus on some surfaces, specifically plastic and stainless steel, for up to 3 days. And again, that's what most medical equipment is made of, so we do need to be very careful about that. Go ahead. We talked a lot about the PPEs that engineers should be using in their hospitals: gloves, washable gowns or disposable gowns, single-use caps or hats, single-use shoe covers, N95 respirators, and eye goggles or face shields are the minimum. We've also talked a lot about how to disinfect equipment and environments in hospitals. Any of the high-level disinfectants on the right are good, and also autoclaving is best whenever you're using a material that can handle high heat for long periods of time. And just remember, gloves and PPEs do not replace hand hygiene. That's very important, whether you're a civilian or someone working in a hospital. In summary, everyone should practice basic hygiene and social distancing all the time, but specifically in hospital settings during a viral outbreak such as this, clinicians and biomedical professionals should adopt increased frequency of hand hygiene, like hand washing, increased use of personal protective equipment, and increased frequency of equipment disinfection. Again, the virus can last up to 3 days on a lot of hospital surfaces, so using proper disinfectants frequently is very important. We have a couple of resources for you. First, most of our equipment specs are taken from the WHO document listed here. You can go ahead and reference that for more details. We also have a great course on the clinical use of ventilators for any clinicians here or anyone who needs a little bit more background. It's called Mechanical Ventilation for COVID-19, and it's done by Harvard University. It's free to access on the edX platform, and you can follow this link to that course. Today, we're going to talk about ventilators and oxygen concentrators. This is a refresher module. We'll move very quickly through a lot of material, but we want to make sure we go over performing preventive maintenance, basic troubleshooting, and also proper disinfection of respiratory equipment, specifically between patients and specifically with a viral outbreak such as COVID-19. None of this is meant to bring someone from zero to maintaining medical equipment, and clinical attachments will actually help you if you ever want to train other people. But we're hoping this can be of value to you, and we'll have a poll up later so you can tell us any troubles you ran into, any more topics you'd like us to cover, and so on. With that, I'm going to turn it over to Guna, and so he can talk about ventilators.
Hi, everyone.
We're having some internet-related challenges with Guna, so kindly allow a few seconds, and he'll be right back on.
Okay, thank you.
So maybe I can get started, and then when Guna's internet catches up, he can just jump right in. And I'll do my best to be as good as Guna for some of you who've already experienced his instruction. Today's session will begin with ventilators. So at the very basic level, a ventilator is a machine that's designed to help a patient breathe, and it provides mechanical support for someone whose respiratory system is in failure. And this is considered a life support device. What are some of the major goals of ventilation? Well, we want to try and decrease the work of breathing that a patient does. We want to improve pulmonary gas exchange, relieve respiratory distress. Ultimately, we want to permit the lung some time for healing and take the stress off of the lung so it can heal itself. In general, the goal is to try and get a patient off the ventilator as soon as possible, because prolonged use of ventilators can actually be quite detrimental for a patient.
Hi guys, can you hear me?
Yes, Gunnar, we can hear you.
Okay, finally. All right.
Welcome.
And that, thank you, Benjin, for the introduction.
You got it.
Yeah, that's a good one. Okay, the next slide, please. Okay, the block diagram. So basically, you got air and oxygen input from, it can be centralized or cylinder line or something like that. Depends on the hospital setting. So when you talk about gas line, you normally got gas mixer, all that. So that's the first block diagram, and you got expiratory valve, inspiratory valve, then your monitoring alarm, microprocessor, power input with the battery, all that. And you got humidifier, patient circuit, filters, and on the expiratory valve, that's a atmosphere output. So basically what happens is, yeah, your breathe out will go back to the atmosphere. So that's the block diagram normally you see in the ventilator. So system structure is basically, you can see a common patient ventilator that you're going to see is, like I mentioned earlier, gas producer, connect external with a mix, everything, and sensor from expiratory valve, inspiratory valve, all this patient circuit that the white
Gunnar, can you hear us still? We're having a very hard time hearing you.
Yeah, I can hear you guys. You guys can hear me?
Yes, we can hear you, but we miss you. We missed a lot of points.
Gunnar, perhaps I can get started again, and as the internet improves, you can jump back in if that's okay.
Benjamin, please go ahead. I think something wrong with the internet.
Got it. Okay. So as Gunnar was explaining, this is sort of the very basic block diagram of a ventilator. It can seem very complex on the outside, but as engineers, we've got to try and simplify this picture down. And so he mentioned some of the key components of a ventilator. You've got the air and oxygen coming in to what we call a gas mixer. Sometimes there's N2O as well involved. And then you've got the inspiratory and expiratory valves. You've got filters that are present, and then humidifiers. Ultimately, you've got patient delivery circuit. And all of this is driven with the help of microprocessors, monitors and alarm systems, and electrical power in the form of either direct power, line power, or you've got battery backup as well. There are also ventilators that just run on pressure alone, and so that's maybe something for a separate discussion at another time. You've all seen a ventilator perhaps at your facility that looks something like this. Some key components involve a support arm that helps keep the patient circuit stabilized. We've got an inspiratory port right about there with the filter attached to it. We've got active humidifier. We've got an inspiratory line. We've got an inspiratory line with a water trap. And then we also have a Y piece. This is a critical component. We will reference this later on. We've got an expiratory line also in some cases with a water trap. An expiratory port. We've got a flexible connector that goes to the patient. And we've got a proximal flow sensor, and in some cases, a nebulizer. This flexible connector sometimes also moves towards endotracheal tube. And this whole component, again, just will be important. We will reference this white piece and this portion of the circuit later on. So here's a very simple illustration of a patient breathing circuit. Now, we're utilizing an anesthesia patient breathing circuit. Again, this is relevant to our conversation today because there's some discussions around converting an anesthesia machine to a ventilator since there's a severe shortage of ventilators. But ultimately, this circuit remains fairly similar to a vent circuit as well. So you've got fresh gas that enters what we call a circle loop, and it comes in to the circuit through a one-way valve, and it goes through the inspiratory limb through a one-way valve to the patient. And you'll have the Y piece that connects the inspiratory limb, the expiratory limb. And then usually right after the Y piece, you'll have a filter, a heat moisture exchange filter. And then you'll see the expiratory limb coming back out through a one-way valve to the vent. On an anesthesia machine, you'll also see what we call the APL valve, pressure limiting valve. You'll see a reservoir bag, and this air will also travel through an absorbent, a CO2 absorbent canister. Now, this is called a circle loop because you see the air comes in, flows to the patient, back out, and stays within the system. And it forms a circle of sorts. Now, as far as a patient breathing circuit itself is concerned, you've got a patient connection that can either be a non-invasive mode of ventilation, or you can have a patient circuit that provides for invasive ventilation. Now, the ventilator is often used for short periods, such as during surgery under general anesthesia, in order to make sure the patient can continue breathing during the procedure. But it can also be used during treatment of a very serious lung disease, such as COVID-19. Please note that a ventilator does not treat a disease or a condition. It is used only for life support. And typically, when it comes to utilizing a ventilator, here are some basic things you have to keep in mind. You always have to conduct system checks to make sure the unit is ready. So we're talking about running a performance test, calibration checks. We want to make sure that the settings, including alarm levels, are correct and appropriate for the patient type and condition. And after connecting the patient to a ventilator, a user must always be on standby to monitor and evaluate the patient. If you are using an anesthesia machine as a ventilator, it is highly recommended that an anesthesia professional be available at all times next to that machine to make sure that it is operating as intended. If you are a biomedical engineer who has been through some sort of training on ventilators, these pictures will make a lot of sense to you. So you've got volume control options on ventilators. You've got pressure control options on ventilators. You've got the number of breaths you can set, the respiration rate. You can set pressure limits. And here's just a basic overview of some of the ventilator modes that are available. Now, for patients that are under severe respiratory failure, you need the ventilator to do a lot of the breathing. But as patients start to improve, they start to breathe on their own, you are able to activate synchronized modes on the ventilator. That way you can wean the patient off the ventilator. Again, the longer a patient stays on a ventilator, the more damage it does. And so you want to try and wean a patient off the ventilator as soon as you can. Here are some of the most common vent modes. The CMV, which is the controlled mandatory ventilation. The CIMV or the CIMV, synchronized intermittent mandatory ventilation. CPAP, continuous positive airway pressure. And ACMV, assist control mandatory ventilation. Now, we will make sure that you have access to these slides so you can reference this information. We want to quickly get to preventive maintenance and corrective maintenance. The drive mechanism. Sorry, come again?
It's good to go back to go to the maintenance parts. It's good.
Okay, okay, perfect. Good, 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 good. So please remember this HME and HEPA filter configuration. So HME is basically just the heat and moisture exchange. And then you've got a HEPA filter that filters out particulates from the circuit. This distinction is very important because for the COVID-19 patients that you're treating, we want to use both the HME and the HEPA filter. Otherwise, you will be recirculating the virus through the anesthesia or the ventilator. Oh. Now, you have a combination of this called the HMEF, and you may have seen it. And so that's HMEF is a combination of both the heat moisture exchange as well as the HEPA filter. We usually recommend, as per the protocols that they've put out, that if you're treating a highly infectious patient, you want to use 2 HMEF filters in the circuit. One will be attached right after the white piece before it gets to the endotracheal tube. And another one they recommend that we attach to the expiratory limb. Here's a picture of what that looks like. This would be what we consider an HMEF filter. And here are some more pictures of the configuration. Before it gets to the patient, you will find the filter. Here's another shot of that filter placement. Right as the white piece moves towards the endotracheal tube or the mask, you'll have a filter, and then you'll see another filter at the expiratory limb. We've put some specifications for ICU ventilators on these slides that you will receive in an email after the presentation. These are from the WHO disease commodity packages, and these are the basic specifications for the ICU ventilators that is recommended as a part of the COVID-19 disease commodity package. You'll notice some of the phrases here that we've already gone over. And I'll hand over to Guna now to talk through the different maintenance procedures. I think we're still having challenges with Guna dialing in. And so I can continue with the presentation. So we will begin with some cleaning procedures for a ventilator. For a patient breathing circuit, it is recommended that you clean the circuit multiple times in a day. You want to monitor for water accumulation, drain and clean as necessary. Please note, if you have a patient that is COVID-19 positive, coronavirus positive, be very careful as you handle liquids. You want to dispose of the bacteria, the HEPA filter. The recommendation is that you do that every 4 hours if you have enough supply. If not, you definitely have to replace that filter between each patient. Always inspect this filter, and if you see any excessive resistance in the breathing circuit, you replace. And again, overall, for a ventilator, you're always constantly monitoring for water accumulation, and you're always monitoring the condition of the filters, the heat and moisture exchange filter, as well as the HEPA filter. As necessary, between each patient, if it is a single-use disposable circuit, you encourage them to discard that appropriately. If it's reusable, you will sterilize and replace it between each patient. The outside of the ventilator, the body, the control panel, the cart, the support arm, you will wipe down with a clean, damp cloth and mild soap solution. If it is in a maintenance area, so not in the patient care area, you bring the ventilator to a maintenance area, you have to vacuum dust off the ventilators on the rear panel, ensuring that you wipe off all residues after cleaning. If you want the recommendation of cleaning solutions, we covered that last week. You can reference the materials from last week, or we're happy to get that information out to you if you ask for it. When it comes to sterilizing patient circuits, you're looking at autoclaving reusable circuits. And we've got some temperature that we've listed out at 132 degrees centigrade for 3 to 5 minutes, 126 degrees centigrade for 10 minutes. And if it's at 121, you sterilize it for 15 minutes. Please make note to look at the packaging instructions of the reusable circuits. We covered this last week. You want to look for the very specific instructions on your reusable circuits. This way you will know at what temperature and for how long to sterilize. Next, we'll start moving into some other components of the preventive maintenance. We do preventive maintenance to reduce the risk of injury, to decrease equipment lifecycle costs, and to avoid operational difficulties. In some countries, there are very strict codes, standards, and regulations, and so preventive maintenance allow for health facilities to comply with these codes, standards, and regulations. All of the planned preventive maintenance procedures can be divided into these 4 categories: qualitative tasks, PPM tasks, electrical safety tests, and quantitative tests. The qualitative task involves just a simple visible test. You're looking for any wear and tear on the machine. Planned preventive maintenance tasks include performance verification tests. Electrical safety tests involves ensuring the electrical safety of that machine, and we've got a checklist that we're happy to share with you that covers all of the various components of the electrical safety test. Here are the tools that you will need to conduct preventive maintenance and corrective maintenance on a ventilator. You will need an electrical safety analyzer, a vent analyzer, a test lung, and a multimeter. With the vent analyzer, you're looking for all of the connectors. And again, if you want a comprehensive list of what comes with the vent analyzer, we're happy to provide that list to you. Please ask for it in the chat and we'll be sure to include that. As a part of the vent analyzer, a lot of you may have seen this specific component, the oxygen sensor. This is very critical because this is what you will use to calibrate the oxygen sensor on a ventilator. Usually, for those of you who've had the hands-on sessions in our training programs, you know that we have to begin at, you'll start with 21% calibration, which is just with atmosphere. And then you will increase the gas, oxygen, and you'll calibrate it at 100%. Now, this calibration is done during maintenance or after the oxygen sensor has been replaced. Flow sensors are another component of the ventilators that need to be looked at. Before you calibrate a flow sensor, you must always check to see if it is moist or it needs to be cleaned. Especially in anesthesia machines or ventilators where there has been an accumulation of moisture, flow sensors will be degraded. And so you want to pay very close attention to your flow sensors. Make sure that these are clean and there's no moisture, as it'll cause damage. Now here are the sensor configuration, the flow sensor configuration. You'll have a proximal flow sensor between the Y-piece and the patient. You will have an expiratory flow sensor, which a lot of you have seen outside the ventilator. And then you'll have an inspiratory flow sensor as well, usually located on the inside. In its single link configuration, you will see, again, an inspiratory flow sensor on the inside, and you'll have a proximal flow sensor between the expiratory valve and the patient. But the most widely found circuit configuration is this one on top that we've just talked through. I've seen circuits where people do not use the proximal flow sensor. And so a lot of you are probably familiar with the expiratory flow sensor that you've seen. Here are some pictures that'll help you visualize it better. So from the ventilator, you'll have an inspiratory flow sensor. And if there's a humidifier in the circuit, that you may not have a humidifier, but if there is, it'll go to the humidifier out towards the Y-piece. And between the Y-piece and the patient, you will see the proximal flow sensor that looks something like this. And from the expiratory side of the Y-piece, you trace the limb back to the vent and you'll see an expiratory flow sensor. The flow sensors are used to measure all of the important parameters of a ventilator. These are extremely key sensors, and they're very similar to an anesthesia machine. The test lung is used to check if the ventilator is working properly. This includes checking for leakage in the circuit. The standard volume for a test lung is 1 liter. We will go through the test setup so you can all refresh your memory. Here's a test setup of all of the certain pieces we've talked about. You've got the controller module for your vent analyzer that connects to the high flow module. You'll have the HEPA filter. You'll have the oxygen sensor. And so you'll see that the inspiratory limb will be connected this way. And the expiratory limb will be connected from there on. Here's another picture of the configuration. If you have the test equipment, you'll have the Y piece coming in to the filter. You'll connect to the patient outlet. You'll have the high flow module. Going to the test lung. Please note that this length between the high flow module and the test lung should be short. Here's another picture of the setup. Again, you see the filter, you see the high flow module, you will see the oxygen sensor, you will see the test lung being connected. And this is just the basic circuit configuration for a vent analyzer. I'm going to quickly go back and go through some electrical safety components as well. This is a very commonly found electrical safety analyzer. And here's a checklist of an electrical safety report. You're looking to verify the main voltage, the ground wire resistance, and you want to look for earth leakage current and the enclosure leakage current measurements. If you need this checklist, we're happy to share this with you. For the ventilator itself, once you've attached everything as per the as per the pictures we've shown, once you've connected it to the high flow modules, here are some of the parameters you're testing for: the tidal volume, the breath rate, the O2 concentration, and the PEEP values. You want to test it, you want to set it at a few different values and test the various limits. You want to record all of the measurements and ensure that it is within range. For a slightly more expansive ventilator test, you will go through an O2 failure alarm, the air failure alarm, breathing circuit leak, here are some pictures from the vent testing that you will do. Once you've started the test, you'll set up the tidal volume, the breath rates, the IE ratios, the PEEP values, and your test device should give you something of these sorts. You will see the IE ratio here is 1 to 1.7. The ratio that was set is 1:2. And so this would be considered pass. Also, the breath rate is being recorded at 14.6. We set it at 15, and so this would be considered passing. Here's a troubleshooting chart with some commonly found errors on ventilators. If there is water in the circuit, you want to clean or replace the water trap kit. Also, if there is excessive water in the circuit, you can consider increasing the fresh gas flow. If there's oxygen sensor alarms, you want to go ahead and calibrate the sensor. And if that does not work, you want to replace the oxygen sensor. If there is AC power loss or battery backup alarm, you want to check the batteries, discharge, and charge the batteries. If the safety valve has popped off, you will hear an open, in some cases, a whistling sound. You want to check the high pressure that has been supplied, and usually there will be wrong, incorrect, the wrong regulators, the wrong specs on the regulators, industrial grade regulators, or the line connection could be blocked. If there's a gas flow sensor alarm, you want to check the gas flow sensor and oxygen sensor. Make sure you perform the calibration. If there is a CO2 alarm that persists, you want to check and replace the exhalation valve assembly. Now be very careful when you do that. When you check the exhalation valve assembly, oftentimes you'll find reusable exhalation valves, and they've got O-rings, and they've got just rubber pieces in there that you want to be careful while handling, unless otherwise you will tear it when you're taking it apart. So here's a quick short summary with your ventilators. Make sure you sterilize the ventilators between each patient. Sterilize the breathing circuits. Make sure you exchange the expiratory filters, which will be the HEPA or the HME filters. And be sure to wipe down the machine front to back, including the screen, the sensors, cables, and other touch points. Now for today's short discussion, we want to go through utilizing ventilators, anesthesia machines as ventilators. There's a severe shortage of ventilators in most health systems. And with the COVID-19 situation, pandemic, there's been a huge stress on the supply chain. And so people are considering and actually recommending the use of anesthesia machines as ventilators. Before we get there, we do want to say that normally we would not recommend the use of an anesthesia machine as a ventilator. Two of the key reasons are the ventilation component of an anesthesia machine isn't meant to run for days at a time. Usually, the anesthesia machine is designed to be reset and recalibrated every 24 hours. And some of these patients with COVID-19, they end up being in ICU care for several weeks. And so it was not designed for that. Anesthesia machines are very necessary for safe surgeries and should not be taken away from the operating theaters. However, under the current circumstances, the need for ventilators is much greater than current supply. So if you don't have enough ICU ventilators at your facility, you can use your anesthesia machines.
Benjamin, you seem to be muted.
Hey, can you hear me now?
Yeah, we can.
Okay, good. So with anesthesia machines, the ventilators are allowed allow for rebreathing of exhaled gases. And so this is why this is another consideration that we need to take into account and avoid using anesthesia machines as ventilators on COVID-19 patients if possible. But again, under very serious considerations, we will give you a few steps that you can take to try and do that. Make sure that an anesthesia professional is available at all times and checking in on the machine every hour. Always use 2 filters in the circuit. This way you can reduce the chances of cross-infection. And please note that the anesthesia machine is not protected against non-authorized users like the ICU vents. And so you'll need to reconfigure the alarms to make sure that the alarm volumes are loud enough to get your attention. You will begin by removing all the vaporizers on the anesthesia machine. If possible, you will convert the drive gas from oxygen to air. Not all anesthesia machines are capable of doing this easily. If you reference the technical service manuals, they will give you detailed steps on how each anesthesia machine, how you can change the drive gas on each anesthesia machine. If you have anesthesia machines at your facility that you want to convert to a ventilator, you can send us the model, the make and model, and we're happy to find the technical reference manuals for you and give you detailed instructions on how you can change the drive gas. Again, you'll ensure that the breathing circuit has HME F, the HME filter, at the endotracheal tube connection. You'll attach a second filter at the expiratory limb. The recommendation is that you replace these filters every 4 hours if there's enough supply. Ensure that there's a large reservoir bag that is connected. You will set the alarm volumes to maximum and check the alarm limits. As an example, the inspired carbon dioxide alarm needs to be set at 5 millimeters of mercury. You will keep the CO2 absorbent in place. You will set the fresh gas flow to minute ventilation, or that is 6 to 8 liters per minute for adult patients. Make sure you flush the machine to ensure that you remove all of the anesthetic agents from the system. You will set the APL valve to 0, and then you're able to change the mode to vent mode from the manual manual bag mode, and you should be able to use your anesthesia machine as a ventilator. Please remember to ensure that there is no leakage, especially around the endotracheal tube. You want to monitor the humidity in the circuit every hour, periodically draining water from the breathing circuit hoses, and replacing filters as necessary. If there's a lot of humidity in your circuit, you can dry the circuit by replacing the filters and increasing the gas flow. Please note that you do not want to do this for really long times, as that can dry a patient's airway. You want to check the CO2 absorbent every hour and replace as necessary. After each patient, dispose the filters and the disposable circuits. Disinfect and clean the machine after each patient. I'm going to pause now for a few minutes and take any questions you may have. I'm sorry for some of the technical difficulties we faced today as a part of internet-related challenges, but we're happy to answer the questions that you may have right now.
Okay, I see a hand raised.
Hello.
Yeah, we can hear you. What's your question?
Okay. My question is just to make sure the function of the proximal flow sensor. I don't understand about that.
Sorry, can you say that one more time?
Can you hear me?
I can, just barely. You asked about procurement of what?
The proximal flow sensor.
Yeah, Awed, so are you asking about the procurement of the proximal flow sensors?
The function of the proximal flow sensor, yeah.
Ah, yes, okay. So the proximal flow sensors allow for a better reading on the flow rates to the patient. So the general idea of having as many sensors as possible is because the patient circuit can sometimes be very long, especially if you add humidifiers, you add multiple filters in the circuit. And so you've got inspiratory and expiratory flow sensors that allow you to measure for flow and pressure at close to the ventilator, but the patient's still on the other end of the circuit. And so proximal flow sensor allows you to get better readings right at the point where the air enters and exits the patient airway.
Okay, thank you.
Thanks, guys. And there are a couple of questions in the chat about sharing the slides in the recording, and we'll make sure you all get the copy of this document as well as the full recording. So you should be able to see everything, both voice and slides, whose internet is a bit slow.
Hello.
Yes, we can hear you.
Yeah. So this is Bontu, and thank you for this training. It's really quite helpful. I have a couple of questions.
Yeah, go ahead.
So one is what is opinion from the biomed perspective on sharing ventilators between more than 2 patients? Because as we see with monitoring, it will be quite difficult to monitor more than 1 patient with one ventilator. I want to know how it is done, because of the other is on cleaning and disposal of consumables on the ventilators. So what is a proper way of disposing, especially with the consumption of these filters like every 4 hours? So we'll have a pile of, I mean, these bad filters will be piled up, so that we will have a massive waste. So what is the protocol on this, on the disposal of these filters? Thank you.
Really good question. Thanks.
Yeah, those are great questions. Dr. Mazurshal, I would love for you to speak to the disposing of filters, especially in context of Ethiopia and some of these, the East African context. What would that look like? What would you recommend?
Hello everyone, this is Mas. Can you hear me?
Naz, we can hear you.
Yeah, good. Yeah, I think when it comes to disposal in Ethiopian context, yeah, it would be putting the filters in garbage as usual, and then the cleaning people will take it to the incinerators as usual. I don't see any other way of disposing the filters right now. So I mean the nursing healthcare workers will dispose it to the nearby clean, and then from there the cleaners will take it to the incinerators for burning. That's it.
Thanks, Maz. And I think the other question was about sharing ventilators among multiple patients.
This is Ayuel speaking. I'm hearing from United States. I have one question. I have certified and trained in Philips mechanical ventilators, and working for the last 5-6 years on it. And my question is, you said after one patient discard the filters. So the Philips mechanical ventilator, the exhalation filters are reusable. So what if we autoclave some of them? Thank you.
Hey, thanks for your question.
Hello.
Hold on one second, guys. So we're going to go through one at a time. I think Bontu had another question. We wanted to talk a bit about sharing ventilators among multiple patients. That's a bit of a clinical question. But Benjamin, do you have any?
Yeah, I can quickly respond to that. So as of right now, I think there are some experimental procedures being done to see how effectively they can have 2 patients at the same time on a ventilator. The scope of our training does not cover that type of adaptation. I think it requires a lot of close scrutiny by clinical engineering societies that are involved in that type of study. I would say for most of the context, the ventilators that we've seen in use in the East African context, you stick with one patient to one device. And especially if it's a COVID-19 patient, you want to try and dispose of the disposable circuits, and whatever components are reusable, immediately put it through a sterilization process.
Thanks, Benjamin. And then I think the next question is whether expiratory filters are reusable. I have an answer from Guna here real quick. I'll just read it off for you from WhatsApp. He's suggesting that you do change the filters between patients, specifically because COVID is a virus and it's highly transmittable. So we have some questions from the chat. Let me go ahead and read some of these off. So when it comes to using anesthesia as a ventilator, the vaporizer is in place, but what about soda lime and replacing the soda lime for? I should mention, I believe you need to remove the vaporizer. Is that true, Benjamin?
Correct, absolutely. So we want to remove all of the vaporizers from the circuit. You will remove the vaporizers from the circuit. You want to ensure that the CO2 absorbent is in place. Part of the reason is because the anesthesia circuits are designed for rebreathing, right? Because you want to minimize waste. And so if they're rebreathing, you will need to filter out the carbon dioxide from the circuit. But you do not have to replace the soda line between each patient, as long as you use 2 HMEF filters in the circuit prior to that. So before you get to, if I could just quickly show you this picture. If this is the circuit for a COVID-19 patient, you will have an HMEF filter right after the white piece on this end. And then you'll have another HMEF filter perhaps before it gets to the expiratory valve. And between those two filters, you should be able to capture all of the viral organisms, the virus and bacteria in the circuit. You will only replace the soda lime as it changes color. And I think that's it.
Awesome, thanks, Benjamin. I'll read another question out from the chat. So when we're talking about dual limb and single limb configured ventilators, which one is most efficient, and rather which is the best from a biomedical point of view? This is really a Guna question and we don't quite have him on. He's saying dual limb and single depends on the patient condition. So it sounds like perhaps this is a clinical question. You know, now that I'm thinking about it, because we don't have our expert on the call, we may answer some of these questions better by email after the call. So if these answers aren't quite satisfactory, go ahead and let us know and we'll try to come up with some better answers from our expert later.
Okay.
I'll go ahead and keep reading some questions out from the chat. There's quite a few. What is the problem if we use oxygen as driving gas when we use the anesthesia machine's ventilator?
So, Erin, I'm happy to jump in and take that on. So the problem with using oxygen as the driving gas when you use anesthesia machine as a ventilator is just the waste of it. In a lot of the low resource setting, access to oxygen is a huge issue. And so you want to save oxygen that you have at your facility. And so if you can change the driving gas for it to be air, that's oxygen that you can save for the actual therapy.
Awesome, thank you. And one more question from Abraham. I see you have a hand raised.
Yes, do you hear me?
Yes, we can.
Yeah, when we are talking about the anesthesia machine, what happened to the older version of anesthesia machine who doesn't have mechanical ventilators? Are they supposed to be used?
Yeah, I would not. So first of all, we would not usually recommend the use of anesthesia machines as ventilators. But because of the COVID-19 pandemic, the recommendation is to use newer advanced anesthesia machines that have other vent features available. And so the older anesthesia machines, if they can replace some of the newer anesthesia machines, which can then allow for the newer anesthesia machines to use as ICU ventilators, you can make that switch.
The second question is, we on the presentation to say that we have to use air as a driving gas for the ventilator, not for the patient. Am I right?
Correct. Yes, exactly. Yeah, for the bellows.
Yeah, for the bellow we use to drive the bellow. We only use air, and for the patient we will supply oxygen directly into the system.
Yes, exactly.
Okay, thank you. That's clear now. Thank you.
Yeah, that's a great point of clarification.
Maybe as a recommendation.
Yes, please.
Yeah, I mean, there is no way we can negotiate that. I mean, we have to use the HEPA filters, one for each patient. There is no way that we can negotiate because still we are transmitting the virus, and bacteria are transmitted from patient to patient, and we have huge number of medical teams who are working together. So we have to replace each machine for every patient. We have to replace a new HEPA filter. There's no way, because the virus is spreading. I don't know. It's really hard. So we have to replace the HEPA filter for each patient, and we have to change the patient circuits and clean as has been recommended on the previous presentations. We have to insist to get more HEPA filters to our facilities. Thank you.
Yeah, that is a great point, because if we don't have enough filters being utilized with each patient, you're pumping this contaminated air into the rooms. And so you risk all of the clinical care providers being exposed to this virus. And so this is a great recommendation. And I hope all the clinical engineers, the biomedical engineering professionals on this call, make sure you highlight this to your hospital leadership and the teams there.
Really great insights, guys. I did want to mention that we have opened a poll. This lets you give us a little bit of feedback on what was helpful during the session and what was not helpful. We're running a little bit late, so we will not get to oxygen concentrators today. We'll follow up with that later. But please be sure to share with us if you have other topics of interest in that poll. I'll try to do a couple more questions. Benjamin, do we have a hard stop time? I'm imagining we have another 10 minutes or so.
Absolutely, yeah.
Okay.
We can keep going.
Good. So the next question from the chat is from Dr. Innocent Kizima. Since the anesthesia machine is not designed for use for long hours, how will this change its preventive maintenance pattern? Really good question.
Yeah, Innocent, this is a great question. And so for the anesthesia machines themselves, every 24 hours, we have to do a reset. You have to recalibrate the machine itself. And so you do not have to go through a full-blown protocol of preventive maintenance where you're replacing O-rings and applying lubricants, and you don't have to do all of that. But at the very least, every morning they have to do the functional tests. Make sure they do a self-test, the leakage test, things like that on a daily basis. And then as far as the preventive maintenance itself is concerned, a full-on preventive maintenance, I suspect as anesthesia machines begin getting used as ventilators, if that is a trend we start seeing, the biomedical engineering professionals have to pay very close attention to the corrective maintenance issues being reported. And so if you see that the calibrations are going off, that it's taking longer to complete a leak test, and it's taking longer, the oxygen sensor calibration keeps failing, this is an indication that you have to start replacing the parts on there, replacing the oxygen sensors, cleaning the flow sensors, things like that. And so the clinical engineers will have to track that very closely and move to what we call evidence-based preventive maintenance, instead of just sticking it on a routine saying, oh, I will only do it once a year. Well, no, apply evidence-based preventive maintenance protocols.
Thanks, Benjamin. Another question from the chat from Abirham. Is the procedure for changing the anesthesia machine to a ventilator the same for all vendors?
It is similar, but not same. GE, Traeger, Mindray, they've all started putting guidances out that show you how to change the dried gas. And so if you have a specific make or a model that you're interested in, we're happy to try and find that specific guidance for you.
Thanks, Benjamin. And if you could stay a little closer to your microphone, it sounds like you're a bit distant. And we have another clarification from Kahulablai on the mixing of air and gas for patients. We just want to clarify, we do not deliver just oxygen to the patient, correct? 100%?
Correct. Uh-huh. So changing
go ahead.
So changing the drive gas does not mean you eliminate that gas from being a part of the fresh gas flow, right? So because I change the drive gas from oxygen to air does not mean that I won't have air available as a part of the fresh gas flow to be able to mix that. So absolutely not 100% oxygen to the patient. That will be on as needed basis. The concentrations are based on the oxygen levels.
Thanks, Benjamin. Another clarification from the chat, from previous sessions actually. Can we reuse the N95 masks, and is there any process for cleaning those in between uses?
So this is one that I'm personally not fully sure about. I wonder if there's somebody else on this call that could speak to it. I don't know, Maz, if you've read anything about the N95 mask. I see Sarah from Rice University on the call. Sarah, I don't know if you've heard anything about reusing the N95 mask. I do know of an organization that is actually currently conducting tests to see if they can be reused. I'm not quite sure of any specific guidance yet.
There's been some talk about, hi guys, this is Sarah from Rice 360. There's been some talk about using UV light to reprocess them for reuse. I think there was a message sent out on Infotech about it sometime last week, but I'm happy to forward that to the group for more information.
Sarah, that would be brilliant. We would love to send that out. So if you can send that on, we're happy to include that in the emails.
Awesome. Another question from the chat from Abebe Geberhiwat. Why exactly do we need an anesthetist every hour to use an anesthesia machine as a ventilator?
So part of the reason is because the anesthesia machine uses a circle loop system. And so it requires constantly watching for moisture in the circuits. It requires constantly watching for the CO2 absorbance, looking at the reservoir bag to make sure that there's no pressure building up in the circuit. There's a lot of other things that come into play besides just turning on a ventilator. And so this is why if you have an anesthesia professional around who can check in on that machine at least once an hour, they can ensure that the device is still performing as the vent parameters that has been set in place.
Awesome, awesome, awesome. We're going to take one more question. Somebody who has trained and certified with Philips ventilators has mentioned that exhalation filters are reusable for the first 100 patients. According to Guna, not all HEPA filters are reusable. Perhaps from Philips they could be, but again, for COVID-19 as a virus and a very contagious virus at that, it is advisable to replace between patients. You've also asked about how easy it is to discard between patients and the affordability of that, and that will change dramatically based on your context. And again, you just want to be sure that you don't use a filter from a COVID patient on a non-COVID confirmed patient. You would not want to risk that cross-contamination. I see one more raised hand, Geber Hiwat. Please be sure to unmute yourself before you speak.
Is the UL still in? Maybe he can talk more about that. The Philips certified engineer. UL?
Hello?
Are you here? Okay. Maybe you can talk more about it.
Yeah. For the COVID-19, when we use the anesthesia at the ventilator, the virus will not stay in the soda line for the next patient.
Yes, that is the great risk.
Thank you, Dr.
Because they use a certain
yeah, I have
loop.
been trained Philips mechanical ventilators, and on the exhalation filter it says discard after 100 patient, which comes first, or after 1 year it says. So we use the exhalation filter for 1 year or like 100 patients. So after that we discard. The inhalation filter, of course, we discard after each patient, but still affordability is the question. We don't have access most of the time, so that's the problem. The shortage, there is scarcity of the filters. So how to consider that? Thank you.
Thank you so much, UL. I was responding to a point brought up earlier about the virus staying in the anesthesia breathing circuit. And I just do want to flag that is the concern with the closed loop circuit. But the guidance put out, that is being put out, it seems like if you can use 2 HEPA filters, 2 HME filters in the circuit, you will greatly reduce and you will be able to use an anesthesia machine as a ventilator for a COVID-19 patient. So as long as you have 2 HME filters in the circuit at the spots where we talked about earlier, one by the ETT or the endotracheal tube, the other one right before the APL valve, we should be, the machine should be safe for reuse. Again, after each patient, we recommend discarding the filters and disinfecting the machine, as well as sterilizing the reusable circuit.
All right, thanks again so much for your questions. I know there's still a few more out there floating, but we're going to have to close this call. We will send out the slides and also the recorded session by email. You should receive that shortly. Anybody who did not register for this call and still wants those items, you can email us at assisthtm@assistinternational.org, and we will be happy to add you to the list. Benjamin, any closing thoughts?
No, thank you all for your patience. Thank you all for participating and asking questions and engaging. Our thoughts are with you. And again, something that Erin referenced earlier, if you can send us notes, please fill out the poll and let us know specifically what subtopics you want us to cover. As an example, maybe for the ventilator, some of you who've been through our training program, this is meant to be a refresher program. And so you probably understand some of these concepts. But if any of you have an issue with how to measure, say, PEEP value, or how to set the ventilator to be able to measure for the IE ratios, please reach out with specific questions, and we can tailor
training sessions around those. So thank you again for your time. Erin, thank you so much for being a great moderator, and we look forward to having you all join us next week.
Okay, thank you.
Thanks, everybody. Have a great day. And again, that poll is still open for another 4 or 5 minutes so that you can finish up.
So thank you,
Thanks,
everyone.
everyone.
And good. I'll keep sharing
Sarah.
the link again for the next session.
Thank you. Yordi Kulu Valai.
Thank you so much. This is Musoma team. Very, very thankful.
Kokab.